Hi, and welcome to Part 5, Initial Management of Unstable and Stable Afib with RVR, also known as Fast Afib. Alright, so let's go ahead and start digging into the management strategies of Afib. Let's say you're working in the ED and a patient presents with a complaint of Afib. At this point, you want to try to gather all the information you can to help inform the decision-making process. So first, what's the patient's age? The older a patient is, the harder it's going to be to successfully cardiovert them. What's their past medical history consist of? Do they have a history of CHF? If so, does it look like they're currently decompensated? Meaning they may have some significant edema, positive JVD, or dyspnea, and potentially pulmonary congestion. So yes to any of these is going to dictate our rate controlling approach, if that's what we decide to do. So things like asthma or a history of cardiovascular disease. What are the patient's vital signs? Are they hypotensive? Are they tachycardic or hypoxic? Do they have altered mental status? Now, these will help tell us if the patient's unstable or not. Are they currently anticoagulated? If so, with what? If it's warfarin, you need to check an INR. If it's dabigatran, rivaroxaban, or apixaban, you should check an APTT as well, since these drugs are going to elevate this value. But you just need to remember that there isn't a good correlation between the APTT and degree of anticoagulation in terms of these new agents. It's good to check the coags anyway, because if the patient needs to be cardioverted and they're already anticoagulated, then you're good to go and you won't have to worry about starting a heparin drip first. So let's say that you're working and this patient rolls through the door. You look at the EKG and notice that he's an AFib with a ventricular rate of 180. Do a quick pressure check and it's 80/60. So you know this patient officially has AFib with RVR and he's currently unstable, primarily because of his hypotension. So let's work through the unstable flowchart and figure out what to do. Alright, if the patient's compliant with their AFib meds and have a history of cardiomyopathy, valvular disease, stroke, hypertension, or rate-controlled chronic AFib, and this presentation is significant for a new increase in heart rate, the most likely etiology of this is going to be either sepsis or dehydration. It could also be a GI bleed. If it is a GI bleed, we'll need to check an H&H and then transfuse blood if their hemoglobin's less than 7. If it's greater than 7, we can just go ahead and give IV fluids. We don't need to give a blood transfusion for that. If it's sepsis or dehydration, the first line treatment needs to be fluids. Fluids, fluids, fluids. In most patients, you can just dump fluids into them, especially if they're septic or dehydrated. But you need to be careful if the patient has a history of heart failure, especially if they're acutely decompensated, since they can quickly develop fluid overload. But that's a discussion for later in the year. If they are septic, you also need to give them antibiotics. But I'm not going to expect you to give me an infectious disease treatment plan by any means. Just know that if a person has an infection, it'd probably be a good idea to go ahead and give them antibiotics. After they've been fluid resuscitated, or if it's a GI bleed, after they've received blood transfusions, we'll reassess the patient's heart rate and their blood pressure. If they're still hemodynamically unstable, we're probably going to have to shock the patient, usually using 200 joules biphasic. If we are shocking, it'll be important to give the patient good sedation and analgesia beforehand. Whenever you get shocked, it hurts. I've seen cardioversions where patients were critically unstable and we didn't have time to sedate them beforehand, and you feel bad for the patient because it truly, truly hurts. At the very least, though, you want to give them some analgesia beforehand. The problem with some of the sedation agents, or most of the sedation agents, is that they can lower your pressure further. So if you already have a hemodynamically unstable patient and you give them sedatives, then there's the potential that it could worsen out hypotension. You could potentially use ketamine. It's going to stabilize your pressure, but we won't get into the specific agents for sedation today. That's going to be next semester in critical care. So for now, just know that if you're going to cardiovert a patient, you need to sedate them and provide analgesia before you do. And the other thing you need to do before you cardiovert them, you need to start a heparin drip if they're not currently anticoagulated. But you should have had labs drawn as soon as the patient got into the room, so ideally you're going to have your coag values back. If they're already therapeutically anticoagulated, there's no need to start the heparin drip beforehand. The whole goal is to minimize the risk of atrial thrombus formation, so if they're already anticoagulated, they already have that protection in place. In this critical patient, there's a possibility that if they're not currently anticoagulated, just giving heparin beforehand isn't going to totally prevent a thromboembolism from happening. But at this point, if they're critically unstable and it's because of the fast AFib or the AFib with RVR, then when you look at the risk-benefit, the risk of mortality is higher by not getting them out of that aberrant rhythm and getting back into a normal sinus rhythm than it is by letting it ride out and anticoagulating them for long-term beforehand. So in this case, it's going to be a risk benefit. Let's go ahead and reset back to your unstable patient. Now let's say that this is an acute episode of Afib, so it's new onset Afib with RVR. Remember, this is an unstable patient, so they're going to be hemodynamically unstable. And this is likely going to be due to a decrease in cardiac output because of the high ventricular rate. So with that high ventricular rate, so in Afib, your atria are just basically quivering there in place, and so you lose your atrial kick in that case. And then adding to that, your ventricles are beating completely randomly. They're beating really fast, so your cardiac output is going to be horrible at that point. The faster the heart beats, the worse that cardiac output is going to be. So in this case, in the case of acute Afib, or lone Afib, which is Afib not due to any cardiac reason, this extreme tachycardia and decreased cardiac output is going to lead to that hypotension. So in this case, the best way to fix the patient is going to be to go ahead and cardiovert them. You're going to have a much higher rate of success with cardioverting lone Afib, so the non-cardiac origin. Okay, so now at this point we've cardioverted them. So after they're stabilized, we can go ahead and most likely discharge the patient. But one thing we're going to need to do is discharge the patient from the hospital with at least 4 weeks of anticoagulation. Whenever you shock the heart, it's going to create a state of atrial stunning, which is going to decrease your atrial kick in and of itself. So it's going to create those conditions that are needed to form an atrial thrombus. So whenever you cardiovert a patient, you need to make sure that they're discharged on 4 weeks of anticoagulation at least. And let's go down to the third arm of the unstable. In this third case, we're going to have a patient with chronic Afib with new RVR again, but likely due to noncompliance or subtherapeutic dosing. So either the patient isn't taking their chronic rate controlling agents at home, or if they are taking it daily, the dose has been subtherapeutic. So in this case, successful cardioversion is going to be unlikely. So what we'll need to do is take the approach of blocking the AV node in order to slow down the rate. When we slow down the firing from the AV node, then we're going to slow down the overall ventricular rate of the heart. So we're going to need to find out if they have a history of heart failure. If they don't have a history of heart failure, we can use either a non-dihydropyridine calcium channel blocker, which include diltiazem or verapamil, or we can use an IV beta blocker. If they do have a history of heart failure, then we have to avoid the non-dihydropyridine calcium channel blockers, and I'll go into the reason why in the next video. If they do have a history of heart failure, so is the patient acutely decompensated? If not, we can go ahead and use IV beta blockers. Beta blockers are used for long-term management of stable heart failure, so we can go ahead and use them in a patient with stable heart failure that has Afib with RVR. Now, on the other hand, if the patient is acutely decompensated, so if they have pulmonary congestion, significant dyspnea, volume overload, JVD, in this case, we're going to need to avoid the IV beta blockers. Giving a beta blocker to a patient in acute decompensated heart failure can worsen their overall clinical picture and exacerbate their symptoms. So if they're acutely decompensated, we can't use the calcium channel blockers, and now we can't use the IV beta blockers. So then what do we do? In that case, digoxin is going to be our preferred agent if we can't use the calcium channel blockers and if we can't use the beta blockers. But if the patient has any contraindication to digoxin, then the next drug down the line is amiodarone. Now we're only going to use amiodarone if there is contraindications to calcium channel blockers, beta blockers, and digoxin. So again, if there's no contraindication to digoxin, then that's what we'll use in the event that we can't use the beta blockers and the calcium channel blockers. Now I'll go over these specific drugs in the next video, but I'll go ahead and point out here that digoxin isn't our first line agent for just general Afib with RVR. It's got a very slow onset of action. It's got a lot of drug interactions that come along with it, and we have to use extreme caution in renal failure due to the risk of accumulation. And with amiodarone, it's at the very bottom of the list. It has a slow onset of action, a very slow onset of action. There are a lot of drug interactions that go along with it. It's a pretty dirty drug overall. It's not a great drug for long-term use anyway. But in this patient that has the history of chronic Afib that's not been adherent with therapy, then there's a pretty good chance that he'll have an atrial thrombus. And amiodarone actually encompasses all 4 classes of the von Willems classification. As a class 1, it's a sodium channel blocker. As a class 2, it's a beta blocker. As a class 3, it's a potassium channel blocker. And this is what's traditionally listed as a class 3 antiarrhythmic. And then it also has class 4 activity as a calcium channel blocker. In this case, we'd be using it for the beta antagonism to try and slow that heart rate down. But it's not an extremely effective agent for you, so that's why it's at the bottom of the list in terms of drugs we would use. Okay, so let's just round out this unstable arm again. So if they have chronic Afib and it's new onset RVR and they're compliant with therapy at home, and if they have some cardiovascular disorders to go along with it, history of stroke, history of hypertension, then typically that's caused by either sepsis or dehydration or potentially GI bleed. In this case, it's these conditions that's causing that increase in ventricular response. So the treatment's going to be aimed at fixing the problem that's causing the increase in heart rate, which is going to be fluid depletion. or potentially blood depletion in the case of a GI bleed. So give fluids, recheck if they're still in RVR after good fluid resuscitation, blood resuscitation, then we can go ahead and consider cardioverting them at that point. If they come in with acute new onset AFib with RVR or lone AFib, then the instability is due to that decrease in cardiac output caused by the high ventricular rate. So we can go ahead and cardiovert them in that case and then discharge them on anticoagulation. And if the patient is chronically non-compliant with their AFib meds and it's a new increase in ventricular rate, the cause of the RVR is likely due to the non-compliance, and we just have to control the AV node. In this case, we're going to have to block the AV node and then looking at their past medical history to kind of guide us in towards the right agent for use. Alright, so that is unstable. Let's move up the list to stable AFib. So this is the patient that comes in who has a rapid ventricular response, but they don't have any hypotension, they don't have any altered mental status, their oxygen saturation is fine. They look okay other than the fact that they are currently having a rapid ventricular response. So the first thing we need to do when we see this patient is figure out what the duration of symptoms has been. Did the AFib occur within the last 2 days, or has it been greater than 2 days? So in this patient that has new onset AFib that occurred less than 48 hours ago, we need to figure out whether or not it's lone AFib. If they have lone AFib, meaning it's not triggered by any underlying cardiac disease, and if they're less than 60 years old, we can go ahead and sedate the patient and electrically cardiovert them. You'll need to make sure and initiate a heparin drip prior to cardioversion though. Then after we successfully cardiovert them, which there's a high degree of success in cardioversion, so getting a patient back to normal sinus rhythm, in a patient who presents with new onset lone AFib. So once we do successfully cardiovert them, we're going to go ahead and discharge them, and they'll need to have at least 4 weeks worth of anticoagulation. Now in this patient population, we're not going to need to worry about long-term antiarrhythmic therapy. Since it was lone AFib, non-cardiac in origin, there's a much lower likelihood that they'll revert back to AFib again. So long-term antiarrhythmic therapy is not needed in this patient population. All right, so let's go back. And we have our patient that has onset of AFib within the last 48 hours. And I should mention here that the reason we're looking at less than or greater than 48 hours is you have a lower likelihood of developing an atrial thrombus within the first 48 hours after onset of AFib. At a time point greater than 48 hours, then the risk is much greater that you'll have an atrial thrombus. Okay, so this new onset AFib that's happened less than 48 hours ago, if it's recurrent AFib, or if they have a history of valvular disorder, or are older than 60 years old, cardioversion is going to be more likely to fail. So we'll need to go ahead and control the ventricular rate with IV rate controlling agents. Of course, the patient could always request to be cardioverted, but that approach it's a little bit more nuanced and somewhat beyond the scope of what we're talking about today. So for now, we're just going to work under the assumption that we're going to pursue the approach that's supported by the results of the Affirm trial, and we'll go ahead and administer the IV rate controlling agents. And our goal is going to be to maintain a ventricular rate of less than 110 beats per minute. After we get that ventricular rate slowed, we need to transition them to oral therapy as soon as it's feasible. Then we're going to need to assess their CHADS-2 risk score, which we'll talk about in part 7. Remember that this patient is going to remain in AFib, and that's okay. As long as we can control the ventricular rate and anticoagulate if it's needed, then we're going to be okay. So with this in mind, remember that your goal is going to be to maintain a ventricular rate of less than 110 at all times. And if you're rate controlling them, you're not going to have the goal of maintaining normal sinus rhythm, since they're going to stay in AFib, which is not normal sinus rhythm. The only time you're going to have a goal of normal sinus rhythm, of maintaining normal sinus rhythm, is when you cardiovert them and put them back into normal sinus rhythm. So AFib and normal sinus rhythm are two different things. AFib is an arrhythmia, and normal sinus rhythm is your normal PQRST with normal deflections, normal spacing, normal intervals. So two separate things. Okay, now let's head back here, and let's say that this patient's AFib has gone on for longer than 48 hours. In this scenario, we need to find out if the patient's older than 60, has had a history of recurrent AFib due to causes like hyperthyroidism, pulmonary embolism, surgery, heart attack, pneumonia, pericarditis, or myocarditis, or endocarditis. If yes to any of these questions, then we're going to proceed up to the rate controlling box. So this is going to intersect us with our less than 48 hours. So these merge into the same place. So we're going to acutely rate control this patient. Now, if not, if they don't meet any of these criteria, so let's say they're younger than 60, it's not recurrent, and it's not due to any of these other causes, If the patient wants to be cardioverted, then we can go ahead and do a transesophageal echo, or a TEE. Now what this is going to do, it's going to look in the atria. It's going to help determine if there are any clots in the atria, basically. So we want to take a look and see if they have that clot. Now if there is a thrombus present, then we need to anticoagulate that patient for 4 weeks beforehand. Now this is therapeutically anticoagulate. So we can't just discharge that patient from the emergency department or the clinic or wherever they present to and give them a script for 4 weeks worth of warfarin. They have to be therapeutically anticoagulated for 4 weeks. So if they are on warfarin, that means that their INR has to be between 2 and 3 for 4 weeks. If it takes them 1 full week to get to an INR of 2 to 3, then they're going to have to do 4 more weeks beyond that. So just remember that. It's 4 weeks of therapeutic anticoagulation. After this, once they have therapeutically anticoagulated, then we can have them return and we can cardiovert them. Now, if there's no clot present, then we can start a heparin drip up front, go ahead and sedate the patient, and cardiovert them. And in both of these cases, we need to make sure to discharge the patient with 4 weeks of anticoagulation after they're cardioverted. We've talked about the effect of atrial stunning, so again, patients who are cardioverted need to be anticoagulated for at least 4 weeks after that cardioversion. Now let's move to part 6, and we're going to discuss the specific drugs that we can use to acutely control the heart rate in a patient with fast AFib.